is an assistant practitioner building on the role that is already there as an assistant practitioner. But this one is very much focused on looking at the role supporting acute care settings. In terms of the webinar, we are recording this. So if anyone is unhappy with that, can you please let either Claire Bagley or myself or Polly James know, as we will be recording this and then putting it onto the PPN website. Please make sure you are on mute at all times and your camera is switched off to avoid being the focus of the recording. Obviously, the speaker themselves will be on camera so that you can see them. Any questions that you want to pose to our speakers, we're really keen to get questions from you all. So please put them into the chat bar on the side, and we will be monitoring this and presenting those questions back to you, back to the speakers later on. Any technical problems, please send Polly James an email address. Polly, can you just give them your email or put it in chat? Sorry, it's better probably to put it into the chat side of things. We would like to focus this morning very much on looking at this role and how it has been developed with by Paul Farrand alongside some acute specialists. And then this afternoon, we're looking at how the assistant practitioner role is already working in the Northwest as an apprenticeship and how that has been applied in the Northwest. So it's a sort of two-part, but we'd be grateful if you would all like to stay with us for the entire day. We will be keeping strictly to time so that we will be finishing at 3 o'clock, I think it is. But we will be having breaks in between, so you will have an opportunity to dash up for a coffee, for lunch and for a toilet break. So moving on, if we could have the agenda up, just taking you through. Polly will put up the agenda. Well, whilst Polly's getting the agenda up, just to say that the speakers this morning, I'm just chairing it because unfortunately Anne Horsburgh, who is supposed to be chairing this meeting, hasn't been able to sort the microphone out on her computer. Technical glitches, as you know, do happen all the time. But obviously Health Education England are very keen to be involved in developing this role in its acute context. So firstly, we will be looking at why we need innovation and how this could be applied in care pathway systems in the acute care. And we've got two speakers who are Mr. Andrew McClellan and Dr. Alexandra Hamilton, who are both at the Royal Devon and Exeter Hospital, and they will be talking about how it has been very useful in supporting them to reduce patient stays, I believe. Moving on, a lot of this has all been developed up and thought about by Professor Paul Farrand at Exeter University, who has been working alongside the acute specialists and working on how this role could be developed to be embedded into medical specialisms. And then we're going to look at how we put the pieces in place. So it's all very well having these great ideas, but obviously what we need to do then is develop them into a reality. So how are we going to work that in terms of the educational aspects of requirements, as well as actually looking at where they might sit in different acute specialisms. There will be an opportunity for a panel discussion, so that's why we're really keen to get your questions, and hopefully our panel will help to give you answers to those questions. And there will then be a sort of summary and overarching look at the morning, looking back at the morning. This afternoon's session, which as I say, is focused on looking at how assistant practitioner roles have already been embedded in the Northwest, and learning from them about how we might move forward on this using apprenticeships levies, and looking at how we actually develop up these support roles to support your needs. So there will be a second question and answer session in the afternoon, and then we'll have a short closing summary and actually be finished by 3:30. Hopefully that's what everyone is expecting. Apologies for this all sounding a bit rushed, and I'm just going to check down the notes. If anyone on the planning team has got anything else to add, can you shout now? But if you're happy, I think what we'll do is we'll get started with our first speaker. Now, I understand that, I'm not sure, is Andrew in? Have we got Andrew here yet?
No, we don't. So I'd suggest we go to Alexander's presentation.
Okay, just to explain to people, Andrew Hamilton is actually working as an acute specialist, and in order to try and reduce waiting lists, etc., he has been working flat out non-stop. So we are hopeful that he will join us. He has assured us, but if things have cropped up in the RD&E that we're not aware of, then apologies, but certainly we will get I'm sure, a very good presentation from Alexander, who will be able to support us in learning how it can fit into renal. Do you want to take it away?
Can I just check that you can see my slides?
We can, thank you.
Brilliant.
And I'll put myself on mute now.
Okay, so thank you for the opportunity to speak, and Paul has asked me to say a few words about how this APP role might be useful in our kidney service. So this isn't a role that currently exists for us, and I just want to show you some of the complexities of our service and some of the opportunities for support for our kidney patients. So just a bit of background about living with kidney disease. So 3 million people in the UK have moderate to severe chronic kidney disease. So that's CKD stages 3 to 5 for those who want the technical detail. And if you have advanced kidney disease, then you can encounter all sorts of symptoms. And things we hear very commonly are people have no energy, they're tired all the time. They might be breathless, they might have fluid overload causing leg swelling. They might feel sick, be off their food. Food might taste strange, metallic taste is often reported. And they might have interrupted sleep through cramps and restless legs. And they might also suffer with chronic itching. So you can imagine that that leads to often frequent hospital appointments. And for our patients, often very difficult decisions about choices to make for the different options available when your kidneys don't work very well. So that's different dialysis and transplant choices. We know that people with chronic kidney disease have impaired quality of life. And if you have a kidney transplant, your quality of life isn't restored to normal. If you're waiting for dialysis, if you've got kidney failure that's not requiring dialysis, then you have reduced further quality of life. And people on dialysis, it's worse still. And if you have conservatively managed kidney disease, that gives you the lowest quality of life estimate. There's also impaired physical activity, and common mental health problems such as depression affect a third of people. And that's important because people with depression and kidney disease are more likely to have a more rapid decline into kidney failure, and there's an association with a 50% increase in mortality. So there's lots to deal with there. Now, thinking about our local service in Exeter, from Renal Registry data from 2018, we're looking after 4,000 people with chronic kidney disease, accepting around 120 inpatient transfers for people with acute kidney problems, looking after more than 500 people with kidney transplants, and nearly 500 people on hemodialysis and close to 100 on peritoneal dialysis. And unfortunately, despite all of those numbers, what we have in terms of psychological support is a 20% full-time equivalent clinical psychologist and access through self-referral to TalkWorks, which is part of our local IAPT service. We know from national workforce mapping work that the provision of psychologists and social workers falls short of workforce recommendations. And we also know that for young people, 25% of them don't even have access to psychology. So there's quite a big shortfall in the provision of services versus that complexity of need that we see. Paul will tell you more about the APP role, but some of its key features will be that it's evidence-based, it's fully embedded within the specialty, and it's working alongside the patient throughout their journey. It will collect outcome measure data around mental health. It will support referral into IAPT services for treatment, and it will screen patients and liaise with the multidisciplinary team. We try to map our service locally, and you can see it's very complicated. And I just need to see if I can get my pointer. I don't know if you can see my pointer, but just to talk you through this in a simple way, someone might get referred from their GP and see either a kidney specialist or perhaps a nurse, and a diagnosis might be made, but that diagnosis might require invasive investigations like a kidney biopsy. Then people can have stable kidney function, or they can experience a decline in their kidney function, leading to discussions and the need for education about the different treatment options available. And then people can reach a limbo-like state where they're facing lots of different challenges. So managing the symptoms I've mentioned, they might have unplanned critical health incidents which can impair their kidney function further. They're faced with the choices of different treatment options. They might be having to manage their additional conditions such as diabetes, which can be is a leading cause of kidney failure. And then thinking about managing their hospital appointments, their transport into hospital, who's supporting them, the knock-on effects on their livelihood and finances and employment, and also facing restrictions to their lifestyle and diet and fluid intake. Then there's the different treatment options such as kidney transplantation, the different types of dialysis, or perhaps being managed without dialysis. And these are a bit of a continuum, so you can move between these options. So if your kidney transplant were to fail, that might mean you go back to dialysis. If you're not thriving on dialysis, then you might be thinking about withdrawing from dialysis. So you can move between these services. So it's very complicated. We know from interview studies of the lived experience of people with kidney disease that things that they struggle with are around their body image, around being able to join in and participate, around intimacy, and also around disruptions to education and employment. And these come together under three major themes. So being different and being aware of that, and the desire to be more normal, having to adjust your dreams and ambitions in the face of living with kidney disease, and living in limbo, never knowing what's around the corner from your from a health perspective. So going back to our complicated pathway, there are actually many different opportunities for people to be supported in this journey, and perhaps think about things from a preventative point of view to equip people with self-care skills early in their journey. And some of the examples here are managing concerns, dealing with body image, helping people to stay active with kidney disease, addressing fears when they're entering a period of uncertainty, helping people to solve problems, and when there's a big life change like having a kidney transplant, helping people get structure back into their lives. So I hope I've shown you some of the need for this service and where it could potentially benefit us in kidney services. And I think many of those points would be generic across certainly other kidney services across the UK. So thanks for your attention.
Thanks very much, Alex. That's really great. I don't think that Andrew has yet joined us, so I think what we're going to do is move straight on, and if Andrew comes in, we can always get him to do his piece maybe a bit later on.
Can I just say he's struggling to get on? He's just sent me a text, and he's struggling to get on. He's got some technical problems of his own, it seems.
Okay. Well, whilst he's struggling to get on, what we were going to do was move to the move to you, actually, Paul, isn't it, on the agenda, and maybe if you could give a summary of your talk, and then if Andrew is able to get in a bit later on, what we can do is just rejig the timetable.
Okay, yeah, that's fine.
Are you going to share your slides now?
Polly was going to set it up, but I can see if I can.
Oh, Polly's done it for you.
Nice one, Polly.
So,
if you send Andrew the link again, Polly, he said he'll try it again.
great.
That's what.
Okay, excellent. Well, thank you for everyone who's making the time to come on. If I just introduce myself, and then I'm going to overview how we've implemented the role and how the role will be constructed and how it offers flexibility and the ways in which it offers flexibility to make it a firm contribution to the assistant practitioners more generally, but then also focusing into medical specialties and medical specialisms. So in terms of who I am, I'm Professor Paul Farrand, and I run what we call the low intensity CBT portfolio. And this is an IAPT role, which supports evidence-based low intensity CBT interventions at the moment for common mental health problems, depression and anxiety. And in some ways, the role I'm looking at could supplement that role, but it's not seen as a replacement in any way. That role and the PWP role, practitioner role, is a therapy role. They support therapeutic interventions. This isn't a therapy role. This is using evidence-based psychological practice. And I'll highlight some differences, but it could supplement rather than it shouldn't be seen as replacing in any way. Now, I'm well positioned to developing this area because actually I worked in head and neck, embedded within head and neck services for over 20 years, firstly in the Royal London Hospital and now in the Royal Devon and Exeter Hospital, where I work under the management of Andrew McLennan, who can hopefully get on and talk a bit more about some data we have using some of the competencies from this role that's informed the role and has actually got me quite excited about looking to implement this role wider into medical specialties. So that's really given me the idea, given me the understanding that actually working in medical specialties is very different to working attached to medical specialties as a psychologist. So Polly, could you move on, please? Okay, so it's always good to look at the context first to justify why the role is very timely rather than just some idea we've had. Psychology has been littered with attempts to develop roles, but they've always tended to be ad hoc and come purely from psychology and from a psychological perspective. However, things nationally have. I can see Andrew is going to give his spiel a bit later on because he's just joined us. So nationally, we're seeing a big movement in psychology, both attached but also embedded within medical specialties, for a number of reasons, which I can elucidate later on, but improving patient satisfaction, improving patient treatment, improving patient care, outcomes, and not least to say, reducing costs. And there's massive potential to reduce medical costs, which we know are excessive, through this role. And Andrew will be talking about some data that we've had, that he's collected, audit data that looks at the massive cost savings that are potential to make. But in terms of the context, we have the NHS 5-year forward view, which is pushing towards embedding psychological practice a lot more into medical health care. So aligning the two a lot more. We've also got the IAPT implementation guidance. I should have said I'm on the expert advisory group for low intensity CBT, the National Expert Advisory Group for the IAPT programme. So I'm looking at this from two perspectives, both from the medical perspective, but also the IAPT, Improving Access to Psychological Therapies programme. Now, the IAPT implementation guidance very much pushes the idea of applying psychological practice and therapies into medical healthcare and medical specialties, but it's very different to what I'm proposing, and I will identify some of the differences. So really, the IAPT programme informs the context in which we're working, but it doesn't inform the role directly. So there is a very clear distinction between the two. However, I firmly see this role as supplementing, enhancing IAPT's involvement and movement into medical specialties on an attached basis. There is also now an excellent position paper from the Psychological Professions Network, and they've done a lot of this work with the psychological professions in the Southeast. And what it very much sees in terms of the movement is of psychological practice into medical healthcare is to improve the availability and the quality of mental health care for people in physical healthcare settings. And I think that goes part of the way, and I'm hoping to show you how it goes part of the way, but it doesn't go all the way, because what we have is an opportunity for this role and its embedded nature to actually improve the medical delivery of the medical specialties. So not just enhancing mental health care attached to physical health, but actually working as part of the physical healthcare team embedded to improve what they do and to meet their needs. So it's a different role. It's a different emphasis of the role. My boss, or I won't say it too much, is Andrew McLennan. He actually directs my clinical work, and basically he directs it in a way I enhance his role and that of his allied health professional team. Now, there's a paper which actually goes back to 2001, so it shows how long we've been toying with these ideas. And this paper highlights how every patient has the right to a discussion and interpretation of his or her symptoms within a holistic framework where all relevant biological, psychological and social aspects can be considered. And this is really enhancing the mental and the physical healthcare interface. I think what this is pointing at is fully embedded. It's not looking at attached. It's not looking at still a separation between what mental health professionals can do and what physical healthcare professionals can do. It's looking and it's arguing that should be a firm integration. And Alex has already presented some data and highlighting how that full integration at the biological, the psychological, and also the social aspects would call for such a role as this assistant practitioner to be embedded within the medical specialism that is renal. And we should also be aware that all medical specialties are different. And what I'm hoping to highlight is how this role will accommodate itself to different medical specialties. And I'll show you how I would plan to do this. So once again, it's reinforcing that the psychological will be responsive and working according to the needs of the physical specialty, not just attaching what traditionally psychologists have done. So if I could have the next slide, please, Polly. Okay, so let's step back a bit and just provide a little flesh on the bones to what I've been talking about. Alex has mentioned in terms of renal how mental health outcomes specifically affect and are specifically associated with physical health populations. So there's 4.5 million people with long-term conditions who experience psychological distress, and they're 2 to 3 times more likely to experience mental health problems than the general population, where the extent of mental health problems is bad enough already. And Alex has given you some indication of that specific statistic with related to renal services. One thing that if you work closely within physical health, actually it's okay in terms of having the comorbidity model, but mental health problems are 7 times more likely to occur with multimorbidity. And multimorbidity, because the medics are doing such a good job keeping people alive for longer, even those with long-term conditions, which I should say I also have as well, so I can come at this from a couple of perspectives, then we're looking really at a significant problem. And my argument is we can only really address this significant problem by getting psychology directly within the medical specialties, rather than providing mental health treatment, which is very valuable, but there's other ways to take it forward. What the next quote highlights is that a lot of people with long-term conditions aren't effectively managed well to live well with their condition. And that's what the IACT expansion into long-term conditions is seeking to do. So it's seeking to fill that gap. However, there's still a limitation in how psychology and psychological practice can be moved and integrated into physical health care. And that's currently there are a few roles that apply evidence-informed psychological competencies that can directly enhance aspects of medical treatment as determined by that specialty. And that's what I've been doing for over 20 years in head and neck and oral and maxillofacial. I've been directly enhancing, complementing aspects of their medical treatment through using my psychological competencies. I have been up to now also applying my psychological therapy competencies, because I'm also an accredited high intensity CBT therapist. So I've been able to do both parts of the role. One part of the role would continue in my CBT therapist capacity, but I also have been doing using a lot of competencies that can be used by another role. And that role, I would argue, would be the role that I'm proposing, the assistant practitioner, but to work within the medical specialty. And once again, by being embedded in that medical specialty, they can enhance the holistic treatment and reduce costs. And I'll look a little bit later on, and Andrew's got some audit data that he'll present how we can directly see how we're already reducing the healthcare costs. Could we have the next slide, please, Polly? Okay, so just to reiterate, the model we've had and the model I've argued for a long time, psychological practice has been within medical settings, but it's often been within the therapy model or being applied psychological therapeutic skills to enable patients to overcome particular difficulties that they may have been facing at that point. And the focus has been very much on treating common mental health difficulties, whether they be diagnostic in terms of mental health problems, or whether they be difficulties that could arise with mental health problems, such as helping someone with a transition in terms of Alex's pathway through the renal pathway. And it's turned to, if we look at health services research, it's tended to being explained in terms of two models. That's an attached professional model. An attached professional model is if the physical health specialism needs psychological input, often when there's a significant problem that the patient is facing, that's very much an attached professional model, i.e. the medical specialty makes a referral, often to a clinical health psychologist, who will then come to and provide those competencies as they're needed. But there's often a waiting time, because psychological provision is massively in medical healthcare underfunded. There's not a lot of capacity. There tends to be a big wait, and that is not always consistent with the way medics need to work or want to work. There's also another model that's been expanded through the Improving Access to Psychological Therapies, and that's when there is a dedicated service to work alongside the physical health service. And we're seeing IAPT moving into and having some overlap with the long-term condition service. So in diabetes, so the evidence base at the moment on a national scale, there's some variation locally, but they're working with diabetes, they're working with cardiovascular, they're working with respiratory, they're working with cancer with a positive prognosis. So we're seeing some pilot sites set up, and indeed I know Devon, the Devon IAPT service, have some overlap, and they're beginning to expand into renal as well now in Devon as part of the pilot. But once again, they're working different to what I would propose my role to do. It's not fully embedded. They are more embedded, but they're not fully embedded. And predominantly their role is about picking up on mental health difficulties and then providing treatment for those mental health difficulties. My role is not a psychological therapies treatment. It is using psychological therapies competencies. So let's have a look a bit more at my role. If Polly can move to the next slide. Okay, so first of all, if we look at the diagram, it's very clear that this isn't mental health overlapping with physical health. This is my clinical practice where I'm completely embedded within oral and maxillofacial surgery. I'm under the direction of Andrew McLennan. I'll say that through gritted teeth, but I am very much firmly directed by Andrew McLennan. I'm embedded firmly within his multidisciplinary team. So that means I work as part of as a full member of the multidisciplinary team. I know how they work. I understand what they do. I speak the same language, which I think is vitally important, and it's something that's lost if a professional is purely attached or overlapped. So the stuff I know about Lefortian rotations in maxillofacial surgery, I would argue you could only start picking up on this lingo if you're fully embedded. So the assistant practitioner would seek to integrate mental health and psychological competencies into that specialism. It is not attached. So it's fully embedded as part of the multidisciplinary team. So it's enhancing the dietitians, the rehab specialists, the nurse practitioners. It's enhancing that role. It's not attached. It's not dipping in and out. It's fully embedded. And the role will apply evidence-based psychological competencies to support what they do and enhance the medical treatment. But to reiterate, the assistant practitioner role is not to support or deliver psychological therapy. That would be the IAPT contribution to long-term physical health. When appropriate, therefore, it will liaise with attached therapy models. We'll see a competency is about mental health screening. And if the role picked up on mental health difficulties that required treatment, then by all means, it would liaise with the IAPT services where the IAPT services is working with that therapeutic, with that medical specialty. But it's very much a liaison in that respect. Could we go to the next slide, please, Polly? I see Andrew McLennan says he's still waiting. I don't know if that's if it can be addressed. Now let's have a look to make sure that there's no confusion. This is a step care model, and anyone who's in mental health will be very familiar now with the step care model, which fundamentally begins to recognise different workforces that have different competencies, and it begins to identify that these workforces will work with specific patient groups. So it's very much a therapeutic model at step 2 to step 4. Now, what I'm talking about is enhancing a step 1 medical specialty role. So this is a psychological role, and it is recognised within the step care model. Number 1, step care proposes that the psychological role is based within a community, our community being the medical specialty. And some of the stepped care functions that are recognised at a national level are assessment, are support, psychoeducation, active monitoring and referral for further assessment, and intervention when required. So that would be what I see as creating many of the functions of this assistant practitioner medical specialty role. Could we go to the next slide again, please, Polly? So if we look at workforce development, because as the afternoon, for those that are staying for the afternoon, this is a role that's developing from an assistant practitioner mental health role that already exists. So it is a new functions, but it's extending that role which is already recognised. So we don't have to start from scratch, and that's very good because it takes a lot of effort. So Claire and her team up in the PPN Northwest should be credited with the work that they've done over a long period of time. So, but as with any new role that at the workforce level, it presents challenges. And one of the challenges is recognising how my role will fit in with wider roles that are already there. So that's one of the challenges I'll have, but I will work with other groups to recognise the workforce in which this role best fits. I've done some digging around, and there is a role called health psychology, and in my distant past I was a health psychologist. That's actually my practice, and I became a bit frustrated for several reasons. That's why I moved into doing psychological therapy. Health psychology uses knowledge of psychology and health to promote general well-being, healthier lifestyle, and understand physical illness. As you'll see, what it's lacking is they're not specifically trained to work at the very nuts and bolts, the dirty end of medical practice, if you like. It's still very much providing psychological competencies, but to do different things. Often health psychologists are moving people to positive health. When I worked in the Royal London, I ran smoking cessation clinics, for example. So I understand that, but my role there was very different to my oral and maxillofacial role that I also did at the Royal London. Clinical health psychology, and this comes from the American Psychological Association, they serve people at elevated risk for disease with acute health problems. So they are more attached, but once again, they're serving psychological needs. They're a very important role. It's a crucial role, but they tend to be at the very acute final stages. And medical specialties have a difficulty accessing them because there's not that many. They will change in terms of their role, but their precise role function varies by trust. Now, as you see a little image in the top right-hand corner, I'm not sure if you can see that. There is in the British Psychological Society, there is the Division of Health Psychology. 20 years ago, actually, I was associated with the Division of Medical Psychology. One of my frustrations is just when I started to kick off in medical psychology, the group was disbanded, and colleagues, Laura at the BPS, are trying to understand why it was disbanded. Now, it may be over time, if my role can begin to pick up a momentum, then maybe there's an opportunity through the BPS to actually redevelop that division, because I would see it being separate to health psychology. So we need to have some discussions if we can get the role off the ground as to where this role fits. It presents short-term problems in terms of supervision, but that will be sorted out over time, because over time, as a role develops, you develop the experience and the competencies, then they can take on the supervisory nature. That's what we saw with the IAPT and the psychological wellbeing practitioner. Initially, they were supervised by they were supervised largely by other healthcare professionals, but now they're supervised by what we call Band 6 psychological practitioners. So that will be addressed as the role matures. Next slide, please, Polly. Okay, so let's look at the competencies I would associate with this assistant practitioner mental health to work in medical specialty role. Next slide, please, Polly. Okay, so Claire, there's already this role, assistant practitioner mental health, and the year one of the 2-year training, and there'll be a lot more meat on this role in the afternoon session if you're staying for that, but I'll provide a general overview because I am aware not everyone can. So in the year one, there's generic foundation competencies associated with the assistant practitioner role. And that's very much about professional and ethical practice. That's very much about understanding the interface between mental health and physical health. So it's very much at the level of understanding, and then at the moment doing some general medical competencies such as taking blood pressure. That can actually directly facilitate some of the work that the psychological role in this area can undertake as well. So there's some overlap. What I would argue is the first year is going to be the same. We don't want to reinvent the wheel with a specific year one training that's specific for my role or for the mental health role, although we may see the year one foundations beginning to develop. With respect to my role, we split into 2 parts. The first part is really developing competencies to work in medical settings, which requires their own competencies. So as you'll see in a minute, one of the competencies that this role could have is collaborative care. And we'll see a slide about collaborative care a bit later on. It is a specific intervention. It has its own effect size. So working effectively as part of an MDT team, but also using competencies and ways of working associated with collaborative care has an evidence base and needs to be trained. It's not just MDT working. This module in the training will actually be transferable across all specialties. So we wouldn't need to reinvent the wheel. So when someone goes into year 2, they will do this training and it's transferable because of the nature of the skills and the competencies. Then it's important to recognize different specialties have different competencies associated with them. And we will identify that because I've got some slides as to how the work with renal and the competencies in renal, a long-term condition specialty, are distinctly different from the competencies in oral and maxillofacial surgery. So it's important that this module will be very much developed in combination with the medical specialty it will be attached to. Move on again, please, Polly. Okay, so let's look at some of these. Firstly, these generic medical setting competencies. I've spoken about collaborative care, and I've got a slide next which we'll focus on. And collaborative care is a way of fully integrating physical and mental health care, certainly not attached. It's a way in which physical and mental health care completely merge. I work collaboratively as part of the head and neck team, and I know enough about head and neck. I know enough about working with the specifics to work collaboratively with the other MDT team to work fully. So, for example, I'll administer something called a PHQ-9, which talks about if as one of the symptoms of depression is eating more or less. If I pick up when I'm screening mental health patients that they're eating more or less in head and neck, I will work directly with the dietitian, who can then make sure that the patient, if the dietitian hasn't picked it up, is aware that the patient is maybe under eating because of the symptom of depression, and therefore they will do their job to put the patient in the very best position to actually undergo surgery, resulting in some of the positive outcomes that hopefully Andrew will be talking about a bit later on. They, in terms of the generic medical setting competencies, multidisciplinary working, you need to know what other disciplines do. You need to understand how they work. And what's important is all disciplines differently, and they have a different approach to working, which is important to understand. The role I'm talking about, which will be generic, is mental health screening. We have measures, the PHQ-2, the GAD-2, in which measures depression and anxiety in terms of a screening. If patients moving into long-term conditions or surgical specialties are flagged, then this role would be able to administer the full version, the PHQ-9 and the GAD-7. It will have it's a more reliable measure. But if someone is recognised as having depression or anxiety, then this role will liaise and very much with the IAP team to provide psychological therapy. This role isn't a therapy role, but they will liaise with the IAP team moving into the medical specialty. So it will enhance the IAP long-term conditions, won't replace it. This role will be supportive around signposting and to IAP services or indeed to other services that may be helpful. These indeed include community resources and community services. It may include social care provision. So it will be a matter of understanding those signposting opportunities and trying to close the gap between health and social care, medical care, and indeed psychological provision. It will understand a CBT model and apply it to physical health, which is what I do a lot in getting patients, a certain group of patients in particular. I use this model for atypical facial pain in head and neck and start to get them to understand how sometimes the anxiety that they're experiencing can result in behaviours, and the behaviours they're adopting, such as bruxism, grinding their teeth, which is behaviour that some people adopt if they're stressed, can lead to the atypical facial pain. This role will be able to support behaviour change using something called capability, opportunity, motivation equals behaviour, or selective optimization compensation. These are basic models to use, which can allow people to adapt to the restraints of their physical health care. Because sometimes if you have a physical health problem, you need to learn to live slightly differently with it. These aren't high-end psychological competencies that can only be done by a clinical psychology workforce. These are simple techniques used by many workforces to apply that would be within the competencies of this assistant practitioner role, working closely with patients. They will utilise community resources. Lots of specialties have their own community resources which are underutilised. This role can help utilise. This role would act as an interface between health and social care. The National Audit Office in 2018 had a report on this interface and still argued it's massively underutilised. And this is something that I've done on the ward in head and neck over Christmas. I was liaising with health and social care to set patients for discharge who had some block around they needed accommodation. At home, they were willing to go home, but were reluctant because the resourcing wasn't put in. And I was able to liaise with other members of the team who were able to liaise with health and social care, and we were able to then discharge patients quicker off the ward because they were set up. And once again, this role could enhance public and patient involvement. It's very important in medical healthcare, and these groups are really seen as helping patients. But at the moment, they tend to be unfacilitated or unorganised to the level that they could be really beneficial. Could we move on again, please, Polly? Now, I talked about collaborative care, and I'm doing some work with the University of Washington around the psychological wellbeing practitioner, not around this role in particular. And I've had some discussions with a guy called Wayne Caton, who really is the godfather of collaborative care. And collaborative care is really a way, it's a health services research way of ensuring the patient gets the most out of the team that surrounds them. We see some collaborative care, but not fully collaborative care, but within allied health professionals and within multidisciplinary working and with the medical team surrounding the patient. And I know we have MDT meetings. That's not a fully collaborative care model, because a fully collaborative care model, all the people know the intricacies of the other's role to a point that they're able to pick up challenges experienced by the other disciplines and then create a collaborative way of working. My role, the assistant practitioner, would contribute fully in many ways, a bit like the way I talked about one of the questions on the PHQ9 being about diet and feeding directly into the dietitians to make sure that the dietitians have picked that up. But so my role, however, would be fully embedded in the specialty, fully embedded in the collaborative care team. And that would then liaise with the consulting psychologist, the psychiatrist, because psychiatry have had an interest in this role. I'm not sure if some psychiatrists are on the call, but they certainly express some interest. Also, what this role through the assistant practitioner is pick up some of the competencies I've already mentioned, liaising with resources outside of the direct teams, the specialisms such as IAPT, community, charity. One of the teams we work with, charity, is Macmillan Cancer Relief in oral and maxillofacial surgery. Health and social care, I've already mentioned what I do, but I don't need to do that. This could be a competency this workforce picks up. Patient and public involvement in supporting carers, massively underrepresented. I do a lot of work with carers with research in Sweden. I have an intervention for carers, and I've been talking with Alex, and that's an area we would enhance intervention with carers because they can work more with the people they care for if we provide and support them. There's vocational. We have the vocational employment advisors now set up, linked to IAPT. People with long-term conditions can carry on working, but a lot, or some of them at least, consider that they can no longer do. Employment advisors can have discussions if it's linked up through IAPT or through this role to actually get people, even with a long-term condition. As I said, I work extensively because the long-term condition is able to accommodate my needs. And then alcohol, drug and alcohol and rehabilitation services. So we can seek part of that collaborative care model that this role, I would argue, directly informs. If we're able to move to the next slide, please, Polly. So let's look at some of these generic specialty specific competencies. Firstly, it's an awareness of the medical features associated with the physical health problem and its management. The trouble with being an attached professional is you don't learn the lingo, like I've mentioned before. You don't understand some of the issues facing patients in long-term conditions. So in renal, you have the dietary considerations. I would be able to pick up on potassium levels or phosphate levels in food. So if I'm having a patient, if I'm having a meeting with patient and the patient mentions their diet and mentions issues, if the dietitian hasn't picked up on these, through a collaborative care, I'll be able to link directly in, and this role would be able to link directly in. I know several healthcare assistants who would be brilliant because they know all this and they're looking for opportunities to develop. Psychoeducation. In generic, this role would learn psychoeducation by understanding a CBT model generally, and then how to apply this in their specialties. Now, one of the areas that IAPT is massively underutilized, although I'm willing to be, if someone wants to prove me wrong on this, is a lot of what I do in head and neck is around procedural anxiety. This is anxiety resulting from procedures, that patients have to undergo. I do a lot of this work in head and neck for emetophobia or for blood phobias or for needle phobias. And this role could be seen as supporting a practitioner from the IAP service to undertake brief exposure, which is evidence-based for procedural anxiety. In a surgical ward, it's certainly needed because sometimes you need to move people through to surgery quite quickly. Generic competencies, understand adjustment. Alex has already talked about the massive journey that patients have in renal. Liaison with specialty-specific community and charitable services, and also co-working with specialist services, which at the moment is underutilised because the collaborative care team doesn't have the time to do it. Can you move me to the next slide, please, Polly?
Paul, can I just interrupt you there and just say we are running out of time, and obviously we'd like to get Andrew in since he's kindly joined us. So if you are close to wrapping up, that would be great.
Okay, well, what I'll do is I'll drop some slides off, but if I can have 5 or 10 minutes more, is that all right?
Well, we are pushed for time. We were going to have a coffee break at 11. So if people are happy to give us a bit more time, but obviously we do need to get Andrew in as well.
Okay, well, let me just whip through these. Okay, Polly, if you can move it on. Okay, so this is very quick. I'll let Andrew touch on some of these from his experience a bit later on, so we can move from some of those specific competencies that we would train this role to do in head and neck. Could we move on to the next slide? Now, Alex didn't touch on some of these, so I can quickly talk about some of the ones he didn't touch on. In renal, there's a big movement towards self-management, but a role is needed to support self-management. There is now home hemodialysis. If you looked at Alex's figures, it's not utilised that much because procedural anxiety, people who have a fear of home hemodialysis, and they need someone to support them with the procedural anxiety, but there isn't currently that support. There's also medically unexplained symptoms that through learning about loin pain hematuria syndrome, the role could educate about, not treat necessarily, but educate. There's CBT informed prevention that we're developing in renal. So this is prevention approaches, and prevention approaches stand outside of treatment. And Alex has already talked about the young renal patients groups. Could we move on again, please? Because I still see it's only 11. Now, the benefits of the role are improved quality of life. I've demonstrated that through publications in head and neck. Treatment engagement, and if we can engage patients more in their medical treatment, then they're more likely to be adherent to aspects of that medical treatment, such as in renal, adherent to the dietary restrictions. Satisfaction with treatment will improve. And we know that from evidence that if people are more engaged, and it's holistic healthcare. Now, I've done a very quick healthcare cost saving. Residual kidney function, this is some data Alex gave me. And if we can avoid non-elective hospital admissions for renal, the average cost saving is £1,600 per patient. Lost operating theatre time, I could only find a general figure on this, but maybe Andrew can say more about it, £400 million per annum. Even if that's going to be for a multitude of reasons, but if we can make a little effort to reduce that, I've had many patients who Andrew's asked me to work with at the very last stages of when they're being prepped for surgery because they have procedural anxieties around vomiting, which was something that really opened my eyes, how common that was in surgical specialties, or indeed the more common ones, the anaesthesia or the blood or the needles. If we've saved any lost theatre time, we've saved a lot of money. And then excess bed days, £346 per excess bed day. I won't go in because I'll leave Andrew to highlight that through his Erica data, but we'll see, you can get an appreciation of how much this role will save by moving patients from the wards when they're unnecessarily held on wards, given factors that this role can address. Now, I'm going to leave my part there. I see I'm just 2 minutes. This is going to be a part that's picked up on later on in the day. So I just see I'm 2 minutes overrun, which is actually very good. If anyone knows me, that's very good for me. But I do apologise for running slightly over my time.
Thanks, Paul. That's really great. I think maybe what we'll do is, if people are happy, can we have a 5-minute break now so that people can get to the loo, get a coffee if they need to, because there's been a lot to digest so far. And then if Andrew's happy, we'll get him to come in and do his presentation. And then we can look at the next section before looking at, there's been lots of questions and answers going through. So I'm sure we'll still finish at 12:30 for those that need to go at 12:30. But if we have a 5-minute break now, if we could aim to be back by, well, my clock, it says 11:01. So if we say 11:06, that would be great. And we'll kick off with Andrew, if that's okay. Thank you.